Foundation. And it is our distinct honor and pleasure to host today's session. And our wonderful fellows, 5 of which you'll hear today, have kind of selected the topic today, and it's obesity and spine surgery, safety, outcomes, and complications, things that we should know. And this is a rapidly evolving field, where some newer medications like semaglutide may change or may not change the playing field. Good morning to Dr. Blumenthal, who's going to co-host from the Dallas, actually Plano, Texas side. Good morning, Scott. How are you?
Good morning. Nice to be here.
So curious to hear your all's thoughts about things, and we'll get kicked off. We have 5 presentations, so we're always going to have to watch the clock a little bit, but we do want to have commentaries. We'll start off with our new research fellow who just arrived from Germany and who had co-suggested this topic today, Dr. Julius Gerstmeier. He's from Bochum, Germany. He is really well-dressed, best-dressed man in this room for sure. And he's actually done some research on some of the medications that are behind diabetes control and weight loss and metabolism. So he actually is highly qualified to kick us off on a foundational review of obesity and obesity meds. Dr. Julius Gerstmeier, pleasure to have you here, and take us into some of the medicational aspects that we as spine surgeons might need to know about.
Thank you so much for this warm introduction to Chapman. My name is Julius Gerstmeier. I'm a trauma surgeon in Bochum, Germany, and I'd like to start off this session with just a quick overview of what surgeons need to know about obesity and their medication, and also taking into account a comorbidity, diabetes, to have that combined. So just a quick overview. What we will be discussing today is just an overview of the actual data and the medication, and what then you would need to know, or what you might take into consideration at your own practice. So just to start off, to highlight the actual prevalence of those 2 morbidities, you can almost say it's like an endemic phase at the moment. We have rapidly numbers increasing for both obesity, overweight, and diabetes. So saying that, taking account for the American population, we have almost 3 quarters of the population being overweight, and then almost half being severely obese. So taking into account this kind of numbers, we have to see how many of those patients actually do require medications. So there are big meta-analysis and systematic reviews out there saying that almost everybody, 88.2%, take some sort of anti-hyperglycemic drugs, and almost a fifth of those take more than 3 agents at once to control their glucose levels. In obese patients, it is not so dramatic. We have around 3% of patients taking those drugs or taking other drugs, but those are old numbers. Dr. Chapman also mentioned newer drugs like Ozempic on the market now. We have to see what kind of impact this medication has on the patients. However, we should know that taking medication and controlling diabetes is also very helpful and very beneficiary for patients, because we know that high glucose levels are associated with worsening outcomes. I will go into that a little bit later on in the talk. So those are the current and most used hypoglycemic medications. We should take into consideration metformin as the most used agent, and insulin, of course, but also newer agents like glucose cotransporter inhibitors, which actually have expanded the indications now to renal and heart diseases as well. So we will have to come by, and we will have to deal with those medications more often in the future. Looking at the most prevalent side effects, we have mostly gastrointestinal side effects, but we can also have severe and potentially life-threatening side effects, such as ketoacidosis, lactate acidosis, or hyperglycemia, which wouldn't affect the surgery from a surgical side point of view, but certainly would take it from the risk side of view and from an anesthesiological side of view. We have an increased level of risk there as well. So what should we know from a surgical point of view is that we should pause those medications. We should know that patients are on those medications. And as a rule of thumb, you could say all medication should be paused at least on the first operative day, 1 or 2 days prior to that, and you can restart them earliest the post-operative day with food and nutritional intake. That said, insulin is the only agent we know at the moment to control glucose levels in a perioperative settings. But please be aware that too strict controls of glucose levels may prevent surgical infections, but increase mortality overall. And I think one of my co-fellows will go into that topic even more with one of our papers. So looking into medications even further, there are plentiful of papers out there on metformin and possible good effects. We know that it's antitumorigenic, and we have observed that in the prostate and pancreatic and liver cancer. But we also know that it reduces cell proliferation, migration, and metabolism. Some studies even suggested that metformin might have a second career as an anti-infective agent. But those are all in vitro analysis, and there are some good papers out there looking into human skin cells, and they actually said that it would impair fibroblasts and keratinocytes, which might then affect healing of the wound. Up till now, we cannot really have any clinical recommendations. We would need further studies to assess those topics. Looking into the anti-obesity medications now, so those would be the ones that are currently used for that. Liraglutide and semaglutide are the new ones on there, which we are all hopeful for the effects. There are the side effects. It's on a similar profile as the anti-hyperglycemic drugs. We have dizziness, we have a lot of gastrointestinal symptoms, but there are also some life-threatening side effects that might occur. There's acute kidney injuries and cardiovascular diseases. From a surgical or from an operative point of view, what we should know is that it may increase the risk of aspiration during general anesthesia, because the stomach is emptied at a lower rate. So those medications which need to be paused as well. As a rule of thumb, you could almost say, if the drug is taken daily, you can pause it on the day of the procedure. If it's weekly, you should pause it prior to that. As I said, they may be given straight after surgery, but you should really know that we have gastrointestinal side effects. So for some of our procedures, like lateral interbody fusion or corpectomies, we know that we can have ileasis afterwards or can have gastrointestinal side effects, so that we should take into consideration as well if we want to add even more of that. So in conclusion, we know the numbers are rising, we know those are severe comorbidities, we know that we have to deal with them as spine surgeons as well. As I said, anti-hyperglycemic medication, besides insulin or side insulin, should be paused a couple of days prior to elective surgery and can be restarted as earliest as the day after the surgery. And obesity medication should be paused according to the regime, as I said. It's a rule of thumb to pause them, as I said before. But we should really know about the potential side effects, potential life-threatening side effect, and potentially effects on wound healing and outcomes. Thank you so much.
Excellent, thank you. Julia, so one question, metformin, I always thought was inducing sarcopenia. We talked about this before. Is that a fact, or is that just a rumor?
Well, I looked into it, and different studies suggested different things. So I'd say we have to look further into this matter, because in humans, there were studies that found a little bit of muscle loss, and on a cellular level, inhibiting muscle growth as well. Whereas there are also animal studies out there in mice, on rats, can't remember, but they introduced muscle growth. So I'd say at this very moment, it's hard to tell.
That's a great point. Going to Texas, so Scott, Rick, I find myself in my practice having to advise patients and initiate kind of internal medicine discussions quite a lot. Thank you, Julius. We'll do a change of speakers here whilst I ask my question. Is that the same for you? Do you have kind of an automated process in your wonderful Texas Back Institute where you kind of can just send patients to a minimal metabolism optimizer to not have that discussion, or is this ultimately our responsibility to get patients on the right track?
You know, Jens, it depends on the patient. I mean, some patients are very well or very closely followed, and that's not an issue. Other times when we see our out-of-town patients, we'll have our hospice. He'll give us a heads up and say, hey, look, here's what's going on. His diabetes out of whack. All this needs to be taken care of. He's got this and that. So when they come in to see us, they're pretty well optimized. It's rare that we see them first time and, we say, all right, this needs to be taken care of.
So the other thing I would add is that now with these newer weight loss, it used to be just fen-phen with the anesthetic risk. We've got protocols now for the newer weight loss drugs to screen these patients and make sure that they stop them for the appropriate length of time. Again, according to the regimen for each drugs. And then I don't remember all of them specifically, but certainly with Ozempic being more on the radar screen, that has to be stopped a period of time before surgery, elective.
And since you have so many out-of-town patients, do you actually have them screened? Do they send you their paperwork for their BMI, their whatever, their A1C beforehand, so you can screen them, tell them, hey, you don't have to come yet?
Yeah, Jens, absolutely. And that's where the hospice he'll pre-screen them. And, it's hard with telemedicine. You can get an idea of their body habitus, but we always have them fill out their height and weight. And, I'll ask them to stand by the side and to try to get an idea. But yes, the internist will give us a heads up, say, hey, listen, this guy has all these issues. I don't think that we can do him, in our facility. He really needs to be done where they have an ICU. And it's like, okay, we step back and have a discussion with the patient. And plus they'll go through pre-screening with their internist, but they'll still send the information into our hospice and let him be the final arbiter.
Plus, since we do a lot of anterior lumbar surgery, part of the intake process on the out-of-town patients, besides their MRI, their X-rays, et cetera, is BMI, because above a certain BMI is a no-go for our access surgeons.
Are you okay now? No, Brian is to go. Okay, all right, we'll have a little change in sequence. We were going to have another basic fundamental talk about metabolism, but we'll switch. And Dr. Brian Anderson, he is going to talk about actual surgical applications, and that's actually an article from Texas, I believe, originally, from Dr. Bagley. Brian Anderson talking about impact of obesity and complications and surgical outcomes after adult degenerative scoliosis spine surgery. One of the cases that we're going to do today exactly fits into this category. Brian.
Thank you. My name is Brian Anderson, and the topic or the title of this study is Impact of Obesity on Complications and Surgical Outcomes After Adult Degenerative Scoliosis Spine Surgery. So this was a retrospective case control study. It came out of UT Southwestern, Dr. Bagley. It was a single surgeon study, and it was published in Clinical Neurology and Neurosurgery in 2023. So a little bit of background that is highlighted in the paper. Obesity affects 45% of the US population, defined as a BMI greater than 30. 21% of all healthcare expenditures are secondary to obesity-related conditions, and obesity is a significant risk factor for degenerative spine diseases. Patients are at increased risk of surgical site infections, DVTs, PEs, when they undergo surgery, and previous studies have shown that morbidly obese patients, so BMI is greater than 40, increased complication risk. So the endeavor of this paper was to examine whether post-op complications and outcomes of obese patients, so not BMI 40, but BMI greater than 30, and non-obese patients, those less than 30, how they differ or agree after they undergo ASD surgery. So again, this is a retrospective case control study. They looked at medical records at the single institution under the single surgeon over the course of 5 years from 2016 to 2021. Inclusion criteria were anyone older than 18 years of age, and then any long segment fusion, which was defined as greater than or equal to 4 levels fused for adult spinal deformity. And then exclusion criteria was a history of spinal tumor surgery. So they had 239 patients, and after they excluded 4 patients for spinal tumor surgery, they ended up with 81 technically obese patients with a BMI greater than 30, and then 154 non-obese patients, BMI less than 30. And these are some of the variables that they looked at. I'm not going to read through all of them, but demographics, blood loss, time to walking, their ODI, their psoas muscle index, and some post-op complications. They looked at a milieu of different variables, and I apologize in advance, this is a very data-heavy paper that we're going to go through. Their statistics were pretty routine. Here are some results. So this is an eye chart, but I'm going to try to pull out some of this for you. So things that were statistically significant, the age of the patients were slightly different, but statistically significant. So obese patients were about 3 years younger than non-obese patients. When you looked at the distribution of race, African-American individuals were more likely to be obese, and as were Hispanic patients compared to Caucasians. The BMIs for the non-obese, as you would expect, on average was about 25, and for obese, on average, was about 35. And the ASA classifications were significantly higher for obese patients, making them a higher risk for surgery. Looking at comorbidities, their modified frailty index, both the 5 and the 11, were both elevated for the obese patients. And then looking at patients' SVA was increased for obese patients as well. Interestingly, when you look at the patient's sarcopenia, or lack thereof, it was actually the obese patients that had larger psoas muscle ratios, cross-sectional areas, and also their psoas muscle index was increased compared to those of the non-obese patients. And the non-obese patients had a greater fatty infiltrate in their paraspinal muscles. When we look at some of the perioperative variables of the study, we can see that the white blood cells were elevated, not markedly, but they were elevated in our obese patients, maybe due to higher rates of inflammation in patients with obesity. Anesthesia duration was statistically significant and increased. Blood loss was increased, and the number of days to initiate walking after surgery was also increased. However, these things were decreased in obese patients. Blood transfusion requirement, both fresh frozen plasma and RBCs, and then total transfusion volume. It was actually the non-obese patients who required more blood transfusions after surgery. When we look at the complications associated in patient-reported outcomes, you can see that obese patients had a higher complication rate. Nearly 45% of the patients had complications, compared to only 33% of the non-obese patients. Discharge, only 27% of the obese patients were able to go home, whereas 40% of the non-obese patients were. And then if you look at ODI, there was a statistically significant difference here as well. They were higher pre-op and higher post-op, but if you really look at the data, there's only about a 5 or 6 point difference between both non-obese and obese patients when you compare pre and post-op. And when we look at some of the odds ratios associated with obesity, you can see that patients were 4 times more likely to be African American. They were 10 times more likely to be diabetic, and 4 times more likely to have congestive heart failure. They were 1.8 times more likely to have complications after surgery, and they were half as likely to go straight home after surgery. So in summary, based upon this data, obese patients have a higher rate of comorbidities, anesthesia time, blood loss, rehab time, time required to get up and walk independently. They have higher complications, and they have a higher rate of discharge to a rehab or a skilled nursing facility. However, non-obese patients have higher rates of sarcopenia or paraspinal muscle fatty infiltrate, blood transfusions after surgery, and they also have a higher rate of discharge to home. So the study does have some limitations. It's retrospective in design. There is some treatment bias. There's only a single surgeon that did these surgeries, and so there might be some, there's a lack of variability in techniques and how the surgeries are done. The length of follow-up is moderate, 1.5 to 1.7 years, depending upon which group you look at. And they don't stratify their complications. They discuss the complications that they review, but they don't tell us what complications they were. So we don't know if the obese patients had minor complications after surgery or major complications after surgery compared to the non-obese. And then BMI is, it's as we know, it's just a poor indicator.
Hey, Jess.
Yeah. We gonna say something? No. Okay, carry on.
Yep. BMI is a poor indicator of actual body habitus of a patient. You can have a very large muscular fit male who has a high BMI, and then you could have a cachectic malnourished male in the same regard who has a very low BMI. So some of my last imparting thoughts are the data interpretation is a little bit difficult given the study limitations also, although very intriguing. Certainly, obesity increases the complexity of surgery. There's not a clear evidence for a BMI cutoff in adult spinal deformity surgery. I think people use different values, and the literature is trying to delve down and support a single value, but it's not there yet. Certainly, preoperative weight loss and conditioning, such as prehab, it should be encouraged in all patient populations. We can see the increased risks of surgery associated with our obese patients, and conservative management, it may have a greater role in some of these patients that are obese, given some of the outcomes. But at the end of the day, this study does leave room for improvement, and larger, better quality studies can be done.
So great job. Thank you, Brian. Can you stay up here whilst Neil gets his talk?
Sure.
So just share the podium there for a second. So how do you explain the lower blood loss in the obese patients? That was counterintuitive to me. This is, again, I want to recognize, by the way, Carlos Bagley and his neurosurgery team at UT Southwestern. They've done a couple of really important studies for adult deformities. But how do you explain that?
Yeah, so the blood loss was actually higher. I don't know if I misspoke. Higher in the obese patients.
Oh, okay,
it was about 400 cc's higher per patient on average, but transfusion rate was lower.
Yeah, okay, that's what I meant.
Yeah, so maybe the actual blood volume in the patient, or they could compensate better. They didn't delve into that in the discussion as to why that actually happened, but it is interesting. So
Scott and Rick, is the obesity cutoff that they had at 30, which is kind of the standard cutoff, a pollutant? Did that kind of take away the ability to statistically discriminate one group versus the other? Should it have been 40, for instance?
Well, it may have limited the sample size by going to 40. Yeah. Just because, at least in our experience, there are less patients that we operate on at TBI with BMIs over 40. So at least they have sample size on both sides.
Does Izzy have a weight cutoff for obesity for his deformity cases?
Not as far as I know.
Okay. All right. Good job, Brian. Let's move on time-wise so we get through our speakers. And Neil has reorganized his thoughts, and he's going to go back to foundational talk, and that's metabolic syndrome, a term that's been floated around a lot more, and what it is and what we should know about metabolic syndrome. Is it real? Does it have musculoskeletal side effects that affect the spine? Neil, and he's a chief resident at Penn State, and he's here as an enfolded fellow. Great to have you here, Neil.
All right. So I have the...
wait, I didn't know that was your talk. Okay.
Yeah, this is mine, yeah. So
okay, sorry. MIS surgery in obese populations, retrospective. That's the George Washington University. I misspoke. Go for it.
Okay. All right, so my comparison group, we had patients undergoing posterior lumbar surgery For degenerative disease, you had comparison group of obese versus non-obese and decompression and fusion groups. They have been named at the end kind of here, but I'll just go through. So these patients went decompression versus fusion, and then decompression group was kind of split between open decompression versus MIS decompression. And similarly, fusion groups were also split between open and MIS. And open decompression, again, split between obese patients and non-obese patients. These obese patients were defined at a BMI of 30, which is different than we kind of sometimes define less than 35. So that's something to think of as we're looking through this again. And every group that's defined here was, again, split between obese and non-obese for open and MIS. So table 1 just looks at population demographics, and you had open versus MIS with population age at 54, 57, so not very different. Males, again, if you look at the percentage, 59 versus 49, diabetes, 25%, 27%, smoking status kind of remained the same, and mean number of levels also significant. They kind of looked at 1.7 versus 1.2. Prior history of surgery remained the same, almost the same. Blood loss and operative time were significant in estimated blood loss time and mean operative time, and post-op complications almost kind of were no significant p-values except surgical site infection listed here. And then we kind of talk about disposition as well, which will be at the bottom here. Table 2 in the paper had kind of multivariate analysis listed here for minimally invasive versus open, and you had the surgical site infection that was reduced significantly, and length of stay, estimated blood loss, and operative times, as you can see here. Again, odds ratio showing significant reduction in all of them with minimally invasive surgery versus open. This compares, again, MIS versus open for obese patients who underwent fusion. And again, the age, sex, diabetes, etc., smoking status kind of remained almost the same. Number of levels were significant, 2.1 versus 1.5. Open, of course, a little bit more than MIS. And prior history of surgery remained the same. Operative time was significantly reduced with MIS. So was estimated blood loss, and postoperative complications were also reduced in terms of DVT, pneumonia, PEs, UTIs, and surgical site infections. So overall, doing better with MIS in terms of reduction in time, getting them home, reducing postoperative complications, etc. This kind of compares outcomes of patients who underwent MIS versus open. Lumbar fusion, again, looks at surgical site inspection, length of stay, EBL, and operative time. And again, has operative time is reduced with MIS, and so is EBL, so is length of stay, and surgical site infections are also lower with MIS. Comparison for obese patients and non-obese patients who underwent MIS decompression. Again, this is kind of looking at age difference that they thought was statistically significant, and so was diabetes, but overall, again, some reduction with a minimal invasive surgery versus open. This table goes through, again, obese versus non-obese patients who underwent MIS decompression, and it looks at what we looked at before, and looks at obesity, postoperative complications, odds ratio 3.96, so almost 4. So now we're trying to look at a little bit more of increase with increase in complications with obesity and MIS. And this again looks at comparing these patients with minimally invasive surgery, obese versus non-obese patients, graph showing significant age difference and significant difference in diabetes status of patients. who got fusion, open versus minimally invasive, and post-operative complications and disposition, showing that obese patients had a little bit more issues than not. This compares obese versus non-obese patients who underwent MIS fusion and length of stay, and obesity it definitely increased the length of stay and rehab disposition 3 times compared to non-obese. So I think there's terms of limitations for this study, and what I got out of it was in MIS, with MIS surgery, obesity does change outcomes. And this was a retrospective single institution study. The decision whether or not to perform MIS techniques depends on the surgeon. And now new techniques coming out with endoscopic, et cetera. So that also depends on training as well. Proportion of patients who had diabetes were found to be increased as I went through the different tables and different groups compared to non-obese patients. So this potentially biases the results. And the BMI cutoff was 30. And again, so this kind of changes this is not what we define. We define 35 or lower. So again, if you change that to a higher number, you could even see more difference between patients who are obese versus not, and having difference in outcomes with MIS techniques versus open.
Great, keep that slide up. Thank you, Neil. I'll ask our plastic surgeon, can you come up here, Dr. Gottlieb, and grab one of the microphones? Why would a posterior midline incision that is about 6 finger breadths long heal worse than a paramedian incision such as seen in that white arrow example? This is Dr. Jordan Gottlieb, and he is a plastic surgeon. He is working with you at SNI.
Yeah, I have no idea. I have no idea why those would heal differently. There may be less trauma being done to the tissues. They may have retraction in for shorter periods of time, but otherwise, where the incision is on the back really shouldn't make a difference.
So the midline is not somehow more avascular or something like that?
I don't think so, not in the back.
Yeah, and subcutaneous closure tips and tricks for an obese patient. Should we do a multi-layered closure? Should we look for scarpus fascia and close that? Should there be more subcutaneous drainage? Is there more subcutaneous fat necrosis?
Those are always controversial. When I prefer closing as many layers as possible, but it does leave more suture material in, which are foreign bodies. Most of us are using things that dissolve, so they're not there forever. But my general preference is to try to put all the layers together separately so that if one fails, you still have a pretty good chance of the wounds staying together and healing properly and normal recovery for the patient.
And since we have the benefit of your presence here, midline closure in a healing impaired patient, let's say this lady, and I'm doing a midline incision, should I close with staples or nylon? Does one or the other have a better chance for healing?
I don't think there's a difference. There's no fixed opinion on that.
Okay, there goes that.
Yeah.
I have a statistical observation, then I want to invite our Texas colleagues to speak. Go back to one of the earlier data slides. So when I see statistically significant numbers, this is a great one. Yeah, keep that one. Mean EBL, put your cursor on that if you will. Non-obese versus obese. I don't care whether it's MIS or whatever the comparison is. When I see an EBL with a difference that's statistically significant of 5 cc's or 4 cc's here, let me do my math right, that I have a problem with. That, I'm sorry, that I don't even remotely understand. And if there's a difference of 9 minutes or whatever it is here, that's over time, that's clinically, I would say, not meaningful. It's interesting, it's a smirk, but to put that into the statistically significant category, a highly significant category, I don't get. What I really didn't get in this paper was that there's a length of stay that's, if you go back to some of the others, like 4 or 6 days. There was something in open versus those fusions that was like 4 to 6 days difference. And I love our George Washington University colleagues. They frequently present and they're great surgeons, great doctors. But yeah, Rick, Scott, help me understand. So 6 days, 4 days for limited lumbar fusions. Where does this live? Is this something that is a clinical reality nowadays? How does this number arrive?
Jens, I have no idea because, we'll do multiple level anterior posterior fusions. And typically, I can tell you my personal experience, a 3-level, they'll go home the next day in 23 and a half hours. Now, rarely they'll stay an extra day or two, but you're right. When I see this data of having these patients stay for a long period of time, I'm wondering, in what situation would that be reasonable?
Yeah. No, I mean, this
Yeah, and
is
it's interesting. I look at these last two papers as kind of being like break room kind of papers. They're not going to change anything you do. They don't tell us anything that we didn't know before, but it's kind of nice to have that out there to just say to our patients, we're going to do this surgery on you, but these are the things that you may have greater complications, you may have greater blood, all the things that were described in the past two papers. They're interesting, but certainly didn't tell us anything we didn't already know.
So I'm going to ask Dr. Abdul-Jabbar, my partner, our partner here, to talk about it. So you're a young surgeon, you're very skilled at MIS and open. Do these papers sway you towards using less invasive or MIS surgeries for obese patients rather than non-obese patients?
I don't think so. I think for me, I do quite a variable split of MIS and open, and it really depends on the pathology. So, patients are, I think, again, we talked about that cutoff at 30. For me, that's not someone who's a 32 BMI, that's not prohibitive. So I think that kind of skews the numbers here. If someone is, 35, 40 BMI, I'm probably, going to try to optimize them regardless if I'm going to do an MIS or open. I think these numbers are interesting because in the general population, in MIS versus open, that rate of infection was pretty high. If we look back at that, it was over 5-6%. That's a very high number. And so, obviously that's meaningful, and patients need to know that. And I think that, as we said before, when you're talking to patients about possible complications, preoperative optimization can bring that down, then I think that's valuable, and we should use that in the clinic, but it's not going to change my decision-making.
So one more quick question before we go to Dr. Cliff Pierre. Sorry, we had to get out of our sequence. So when you get that midnight consult, which we get regularly for a BMI 50 plus, now we're talking about serious body mass here, and they're asking us to decompress that patient and fuse them. There's this cauda equinoid kind of a symptomatology present, and assume there's a bad stenosis plus minus a grade 1 spondy, the usual picture. Would you rather do that MIS, or would you do it with a carefully done so-called open procedure?
If there's a question of cauda equina, I'm not doing that MIS. I think that, doing a tubular decompression has its place, but, for me, I want to make sure there's no question that I've gotten a wide decompression, probably doing a more aggressive facetectomy. And if I am doing a decompression, or if it's a fusion case, then again, doing that MIS for that pathology, I think is not the right setting.
Okay, great points. And you said preoperative optimization, Dr. Cliff Pierre, and I want to recognize he's one of our research fellows. He's done a great job. And he, by the way, provides fantastic resources into the chat room for reference articles. Cliff Pierre has looked at preoperative optimization, and this is actually another great paper from our Letterman group colleagues. Can we actually preoperatively fast-track optimization?
Thank you for that introduction, Dr. Chapman. Again, this article that we're discussing is from the Letterman group. Dr. Crawford and Dr. Carrion, more specifically, took a closer look at their early experience working with their endocrinology colleagues in pre-optimizing patients, creating this, what they called a endocrine fast track program. And so that was the primary purpose, just to kind of disclose to the public the results of patients that underwent this program. This was published in the Journal of American Academy of Orthopedic Surgeons last May in 2023. So a brief background was specifically, as discussed earlier by Julius as well as Brian, they disclosed that poorly controlled diabetic patients have increased adverse outcomes when it comes to surgery. More specifically, postoperative mortality was noted here in this meta-analysis. Again, studying patients with hemoglobin A1Cs or fructosamine levels that were quite high in their preoperative evaluations, leading also to surgical site infections, DVT, and as alluded most recently, just prolonged operative stays. And fructosamine, more specifically, measures the glucose levels within about 2 to 3 weeks in terms of defining that period of elevated glucose levels in that period. And so it helps us also kind of create a calculated hemoglobin A1C level using that measurement. And so this is just a valuable marker. This specifically was done in a total joint arthroplasty series, specifically with the hips. And so they found the measurements amongst multiple institutions, calculations, very useful in their preoperative evaluations for patients over the last couple weeks prior to surgery. And elevated hemoglobin A1C leads, as we disclosed earlier, to increased perioperative outcomes. One of the concerns is patients also lack of sufficient knowledge and access to proper care to preoperatively optimize them and improve their blood glucose levels. And so again, the objective is to report their early experience in their endocrine fast track program that they created for elective spine surgery patients. They identified 75 patients that were to undergo surgery. Their hemoglobin A1C levels were greater than 7% during the preoperative eval. They referred them to primary physicians as well as endocrine providers. Their pre-surgery fast track was offered. And this is just a representative image. And so here we see the green star, again, patient is seen in a preoperative setting. They're identified to need elective spine surgery, and then they are again referred to referrals. Some patients did decline this fast track program, either undergoing their own regimen or again, probably being lost to follow-up with respect to their surgical care. Some patients who did elect had periodic lab levels, as well as they were set up with what they called a certified diabetic care education specialist to help assess, to help work with these patients to educate them not only on the medications that they were to take by their providers, but to continue to follow up with their care towards pre-optimizing them for surgery. And again, for those who didn't meet the current levels prior to 2 weeks, they did not pass go and would have, again, further deferral prolongation of their spine surgery that was scheduled. And again, just lastly, again, noting patients that were routed part of the fast track program in or out towards the timing of surgery. And so again, this is just an example of the calculation for hemoglobin A1C using the fructosamine levels for one set of series that they had disclosed here from some of the recent articles. And then again, they wanted to discuss why did patients decline the fast track program, whether it was motivation, travel to subsequent providers, or specifically loyalty to established providers. As you'll see here in the data presented in the next coming slides, they also realized an association of patients who were active smokers that declined the program. They noticed a greater number of the smoking status was higher for those patients. So again, just results here, again, statistically significant smoking status in those who declined versus those who were at least motivated to partake in the fast track program. And those who were actually cleared for surgery, that's a hemoglobin A1C less than 7 prior to actually having surgery, was statistically significant with those who enrolled into their program. And so the numbers was 91% versus 42% of patients that were actually cleared that met requirements with the program. Again, and one thing they noted even after surgery, their last follow-up post-operatively, their hemoglobin A1C remained within normal range. That's less than 7% for most of these patients. And so that was reassuring in terms of just how well the program worked. Limitations are small sample size. This was specifically a single site at Leatherman. One thing that the authors, our colleagues, did not get a chance to share with us was they relied on their endocrine colleagues to take care of the anti-diabetic regimen. However, there were no specifics specifically to what type of medications or the other type of injections that the patients may have taken. As Dr. Julius had mentioned earlier, there's multiple medications that patients are now taking to optimize their care. So one thing we did not get from the article was just what's specific. And as we talked about why patients enroll or not, what's the cost of being part of this program, as well as the time of evaluation, were these patients in there for 6 months, 9 months, 1 year, or greater? And so those are some things that we can kind of either further study or try to get some more from the article. But the take-home message was motivated patients did show an improvement in their blood glucose levels towards preoperative clearance for surgery. And this, again, more study needs to be done to reduce barriers for patient enrollment in such programs as this. And we can kind of do this in a national status.
That was really cool that you found that article. Thank you, Cliff.
Thanks.
So I feel really stupid. Did I miss something? Fructosamine versus A1C. So A1C is one of our
Yes.
epic kind of main lab levels that pops up immediately in our large-scale data assessment things. I've not used fructosamine. Is fructosamine better because it's more rapidly responsive than A1C, which takes like a month to 3 months to kind of change?
Correct. The rationale is that hemoglobin A1C is the markers for a 3-month period, whereas the fructosamine is more acute or subacute, so 2 to 3 weeks, about 20 days, where again it closely or more closely evaluates the patient's current elevated glucose status, and that's that.
So should we here change our paradigm and put fructosamine as one of the main indicator
I didn't get
levels?
that from some of the literature as it should be a paradigm change, but it is a marker to continue to assess patient accuracy towards preoperative clearance. It is another measure that we can kind of use. We don't have anything specifically outside of this in spine, but the others are in total joints or literature. So
I plead ignorance, and I appreciate that you opened up my eyes to something completely new. One of the key things, and this is what I want to ask our Texas friends to comment on, is the thought that not only do we want to and should we as good surgeons try to optimize our patients beforehand, but we actually present as an opportunity to sway patients to change their unhealthy habits towards healthy ones. We're like a gatekeeper for our internists.
yes.
And I love that monopoly slide. Don't pass, go back to jail. So if you don't comply, so we actually are, as a specialty, in a situation where we might have an opportunity to change healthy habits into patients' lives. What do you think about that concept, Scott and Rick?
I think it's good.
I thought fructosamine was a flavor of a lifesaver.
Okay, I'm not the only one. Good, thank you.
Well, I mean, certainly in more so in the deformity world, they talk about, well, and I don't know if you guys do it. I know Sig Bourbon's lectured about it on this format, is what is the frailty index, and obviously, A1C is in it, BMI, nutritional status, things like that. So, I mean, this is just kind of part of perhaps an overall screening process for higher risk type surgeries like revision deformity surgeries, and you're better able to speak to that than Rick or I.
But Jens, I think that it is really important that you have these frank discussion with patients because, again, Scott, in my world is lumbar, TDR, and cervical, but oftentimes we have patients that are overweight, they have diabetes, whatever, and I tell them, I say, look, I can help you, but you have to help yourself. In other words, you have to get your diabetes under control, you have to lose weight. Sometimes they will take heed and they'll say, okay, thank you, doctor. And they go out and they lose their weight, they get their diabetes under control, and then they come back. And then other times I've had patients say, I'm not going to do that. And I say, well, I'm just looking out for your best interest and I don't want to do anything to harm you. So I think there's not enough attention paid to this. It's, we all as surgeons, we say, oh, they have a problem, we need to take care of it. Now, obviously, if it's an emergency, then, regardless of what they look like when they present, they have to be taken care of. But, for the elective, I really think that it's our duty as their physicians to try to help them be as healthy as possible.
So you, both of you are in the anterior retroperitoneum of the lumbosacral junction quite a lot. Is there an abdominal size? Is there some gut size or belly size, a paniculus size that you just say, this is not cool because you'll have wound healing complications, you'll have a postoperative hernia?
Well, Jens, we use the elbow test. In other words, when they lay down on the table, I bend my elbow and put my elbow on the table and I see how high their belly comes up. If it comes above my wrist, then we say no, because, we know how deep it is and how big the instruments are. And, as we talk about the BMI, I really think there should be an adjusted BMI, because sometimes people have a low BMI, but especially males, they're all belly and they have a huge belly and there's no way we can get there. And, their BMI might be 32, which you say, okay, that's not so bad, but they're all belly. So the BMI doesn't tell the whole story. That's a problem.
I love your elbow test. So I have long elbows. I'm not going to use that. Long arms.
Well, I said, then you go a little bit below your wrist.
So the other question I have is, I just wanted to bring that up again. Do larger patients have higher hernia risks despite doing a 2 or 3 layered closure of the retroperitoneum than non-obese patients?
No, you know what? We haven't seen it. And I had a patient recently that we had done a 2-3 level. He was skinny as can be and we did a 2-3 and 3-4, and he did get a little abdominal hernia, but we don't see them very often.
Okay. All right. Final speaker, and he's put together on the quick. He's jumped in. So Dr. D. David Davis III, MD, and he's been great to have you. He's a proud Georgia follower, and he's not going to talk about the omission from the college championship. So
yeah, life isn't fair. But
metabolic syndrome.
All right, metabolic syndrome. And the effects of diabetes and metabolic syndrome on spine surgery outcomes, a recent paper that was a great summary of recent literature. So the authors began by looking at the impacts of diabetes specifically on spine surgical outcomes. And a few recent papers that they showed was, as you could expect, obesity shows worse patient-reported outcomes on outcomes and fusion rates. Pang et al. Did a meta-analysis that showed higher surgical sites infections, and Guzman showed increased complications, length of stay, mortality, and hospital costs. They did look at the effect of specifically insulin dependence, and there is the distinction here that we are not discussing type 1 versus type 2, but rather insulin dependence versus non-insulin dependence in terms of control of diabetes as well. And they showed that while both show an increased risk of complications when compared to the non-diabetic population, insulin dependence specifically shows an increased risk of readmissions in multiple studies. So then the authors laid out some current perioperative guidelines. Classically in the orthopedic literature, guidelines show that you should have a cutoff of no more than 8 or 9% for elective interventions. But specifically in the spine, Cancian et al. In 2017 showed that anything over 7.5% was significantly associated with increased infections and reoperation rates. And so they made the recommendations, and the recommendations in our primary care literature show that you should assess glycemic control twice a year at baseline and quarterly in patients who are difficult to control. This forms a segue into really the crux of what makes this paper interesting, which is metabolic syndrome. And there is a distinction here between obesity and metabolic syndrome. various diseases that increase the likelihood of atherosclerotic cardiovascular disorders, diabetes, and stroke. And it can be diagnosed when any of the three of the following are present, including waist circumference, hyperglycemia, high triglycerides, low HDLs, and then hypertension. And when looking at metabolic syndrome, specifically in outcomes in spine patients, you can see that multiple studies have shown that there's an increased complication rate, prolonged length of stay, and increased costs. He et al. Showed that particularly in posterior interbody fusions, there was an increased risk of cardiac complications and pulmonary complications. There's increased strokes, pneumonia, ICU admissions, and DVTs. As said, the criteria, metabolic syndrome is distinct from obesity. Metabolic syndrome, when compared directly to obesity, shows that you have a significantly greater odds of UTIs. You have a prolonged length of stay and significantly more readmissions at multiple time points. There's more wound complications. And so while the total complication rates are similar, it's important to show that metabolic syndrome exerts a distinct effect separately from obesity. I think this deserves its own slide, that when you look at overall costs of metabolic syndrome to the healthcare system with spinal surgery, compared across multiple studies, the average was a difference of $8,000 per encounter. So in the management of metabolic syndrome, the authors specifically recommended minimally invasive surgery because of the increased risk of wound complications specifically. They also discussed staging approaches and shortening procedure times to reduce the demand, the cardiovascular demand on the patients. I put in italics here because it wasn't explicitly stated, but something that has been close to us here at SSF, Swedish hospital, is a post-operative urinary retention protocol as well, as they have an increased risk of UTIs. And that's something that we discuss here quite frequently. And then obviously working closely with the primary care providers to help patients with lifestyle modifications, because ultimately that's the best tool we have in fighting metabolic syndrome and improving the outcomes for our patients.
Great. Go back to your summary slide of what is metabolic syndrome. Go back. So for me, the question is, not saying we're barking up the wrong tree, but should we have a far more differentiated role in how we look at patients? Should we truly kind of focus more on diabetes 1 versus 2, which you insinuated? Should we have a checklist for metabolic syndrome and have like a risk coefficient? This is what we actually need for risk assessments for especially higher risk patient populations?
Yeah, I think that's really important, and the paper does lay out the void in the literature on this topic, specifically in looking at how metabolic syndrome is distinct, and we should consider it in our surgical planning. So I think that there is having a score and a risk profile would be hugely valuable.
Because in males, I hypothesize, I have no proof, that the correlation of DISH, disseminated idiopathic skeletal hyperostosis, and metabolic syndrome would be super high. I mean, you're right. I mean, you're on call right now. I think you just had another DISH patient with a disaster spine. But isn't that just a 100% almost correlation? DISH patients have metabolic syndrome, vice versa?
Yeah, I think it's an interesting question. You know, why do people develop DISH in the first place? But I definitely think it's kind of a general hyperinflammatory state, which is probably reflected well in these tables with the metabolic syndrome as being a risk factor that would increase your risk for it.
Scott, Rick, should we expand our assessment? You guys have been the trendsetters for preoperative risk assessments. Should we look at metabolic syndrome to be more kind of specific about what we're dealing with our patients?
Yeah, and it's interesting.
Jens,
go ahead, Rick.
No, you finish.
Oh, it's interesting you bring that up, Jens, because I was just visiting clinic up in Coeur d'Alene. It was Roland Kent's clinic, and they do their hospitalists do a very intensive preoperative workup looking at all the medical factors to determine, which patients are appropriate for kind of these smaller hospital facilities without ICUs and things like that. And they're doing big time deformity there, but with careful preoperative medical assessment. I'm not sure it includes metabolic syndrome, but a lot of the things that we've touched on today. And the other thing I'd like to compliment you on, Jens, is getting your fellows to do some of these basic science non-orthopedic paper reviews. We would have a full-scale rebellion if we assigned them topics like that here.
To their credit, they came up with the topic. I thought this was really cool, so we just put it out to them, and they came up with it. And two of them have actually worked in this arena, so I thought this is very cool. Thank you for saying that.
Hey, Jens, I know that we're running out of time, but I do have a question. When I look at the definition of metabolic syndrome, I'm trying to think of the diabetic patients that I treat. There's very few that I think would be classified as having metabolic syndrome. So I wonder if there's any stats on that.
Yeah, let me see if I can throw this up. It's obviously not a part of my talk, but I've got in the paper here. Everybody can see what I've been searching.
And by the way, this is great. This is teaching us spine surgeons a little bit of medicine we should be aware of.
No, I love this about spine. It's the all-inclusive kind of a specialty. It kind of puts it all together, right? Not just four extremities and a head and a torso, but there are metabolic things, there are endocrine things that go all hand in hand with psychiatric issues. I mean, it's really compelling, especially just for that. It makes it so interesting, compelling. So
it really does. And I think that's why a lot of us went into it.
So this paper looked at the NSQIP database, which I've been familiar with in the past, and it looked at this issue that you discussed specifically, comparing metabolic syndrome to obesity.
I don't think we have you on the screen.
We don't have your slide. Ben, can you kick him over, or can you change your screen?
Let me exit out presenter mode. I bet that's my problem there.
Okay.
How's this?
Nice.
Is everybody able to see?
A little bit better. Whoa, text.
So
yeah.
I get my microscope out. Okay.
Yeah, me too.
MIS. This is MIS.
Oh, much better. Much better.
Minimally readable. MRS. Minimally readable script.
So this study that they quoted here was discussed their one-to-one matching with specifically metabolic syndrome and compared to obesity alone. And it does discuss here the odds of, as briefly mentioned, the odds of UTI, prolonged preoperative stays, readmission rates. And your point is well taken, and I think logically is correct. The medical complication rates are similar, but they are somewhat distinct. And so their point, and specifically the authors seem to identify and really hone in on the wound complications and metabolic syndrome when compared to just obesity alone. And I think that makes sense, as metabolic syndrome at its core being defined as risk factors for arterial disease. It does make sense that you would have more wound complications there.
I think we need to do a propensity match study. I actually think that's a very good idea. So we'll need to close out here, but I had a technical question from Dr. Amin Hanin, who's always a very loyal follower. Just to drive the point home one more time, this is for Rick and Scott. For at-risk patients with, and thank you for putting that together, Dave. At-risk patients, should they routinely have mesh put into their anterior exposure sites in the fascia to prevent an incisional hernia or not?
I think with the incidence.
No, I mean, our access surgeon.
You think great minds think alike. We see it in action here. So Scott first, you start first.
Oh, I think with the incidence being so low, I don't know that it would be either medically indicated and certainly not from a cost basis and indicated.
And Rick?
And I agree with Scott. And also, mesh is not benign. There are complications from mesh that I've learned from my general surgeon colleagues.
Great. Well, thank you all. Thank you to our 5 fellows for their great topics and presentations. And Scott, Rick, it's always a joy, and thank you for the online.
This was great. Thanks for educating us spine surgeons in a little bit of medicine.
Cool. Thank you all.
Thanks, guys.
Safe. See you soon. Bye-bye.
Bye-bye.